Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Hopefully everyone's having a good day today. Today we're continuing our acute respiratory distress syndrome advanced series, specifically talking about ARDS phenotypes. For those of you new to the channel, this channel, Whiteboard Medicine, we actually been coming out with a ARDS kind of series. We'll have it linked in a playlist in this video's description, so definitely check that out. If we just go to our homepage here, let's see, not playlist, let's go to videos. You can see that we've had a handful of videos come out recently. Some of these are just for members only at first, so if you have an interest in getting early access to videos, you can check out YouTube membership page. We'll probably end up having 5 or 6, and we'll continue adding videos to the playlist over time. So definitely check that out if you have an interest. Otherwise, check out the channel, different videos, different playlists. We bring you what we would coin kind of public health news as well as medical education. We also have a high yield Patreon page where we will link all the video outlines, free, commercial-free videos, as well as early access to videos and practice questions. So definitely check out that Patreon page if you have an interest. No further ado, quick 30-second break for the introduction. Don't go anywhere. We'll be right back. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer.
All right, thanks for sticking around. So ARDS advanced phenotypes. If this is all going to sound confusing to you, definitely check out our ARDS basics or some of those other videos in the ARDS playlist linked below. It'll give you a much better foundational grasp on things because we're going to kind of dive into some of the complexity here. So acute respiratory distress syndrome. This is actually like many things in medicine that kind of start as these vague syndromes that we then start to better understand. ARDS is actually somewhat of an umbrella term for a heterogeneous group of conditions. And this umbrella term is needed, and we still use it, and it is the appropriate term, but it is kind of an umbrella term that describes a heterogeneous group of different diseases. And anytime that happens, what we often start to do is we start to kind of phenotype, we call it, or subtype. We start to break down this heterogeneity into different kind of subsets of ARDS. Believe it or not, we're actually doing this with sepsis. There's a lot of blossoming data and studies on sepsis phenotypes, and ARDS is no different. If you think about even cancers, right? A lot of cancers are phenotyped. It's not just lung cancer, it's small cell lung cancer, non-small cell lung cancer. And even within that, it's not just, non-small cell lung cancer, it's this profile or that profile. And as we start to better understand some of these large kind of umbrella terms for diseases, we are better able to study them and better able to discover treatments. Because ARDS, a lot like sepsis, hasn't had a huge improvement in mortality over the last couple decades. There has been some improvement, certainly, but there hasn't been a huge improvement. There has not been a lot of studies that have shown different medications or interventions cause significant mortality improvement. Now, there has been some, and we've talked about in one of the videos in here on management, proning, lung protective ventilation, a lot of these strategies to kind of support the lungs, but there hasn't been any trials on this medication, that medication, to kind of identify the underlying causes. And some of the thought is when we come to these umbrella terms, and we just study it as one large umbrella term, that it is difficult to identify therapies because therapies may be effective for a certain phenotype of ARDS, but they may be ineffective for other phenotypes or ineffective for other phenotypes. And then when you just batch them all together, you just kind of get it didn't make an improvement in mortality or this or that, because we're kind of treating multiple different subtype diseases as one in the same. So as we start to understand ARDS and dive into some of the nuances, phenotyping of ARDS is most likely going to become a bigger and bigger thing. And we anticipate that in the future, we will have certain interventions for different phenotypes. So getting into it a little bit more, some of you may know this, and we have gone over this a couple times in different ARDS videos, but the diagnostic criteria for ARDS, the most widespread one, is something called the Berlin criteria. And the Berlin criteria are written below. It essentially requires 3 things. One is you have to have the onset of ARDS within 7 days of an acute insult. We've talked about how this can be kind of a pulmonary insult, pneumonia, aspiration pneumonitis. It could be non-pulmonary, pancreatitis, trauma. Some of these systemic diseases that cause systemic inflammation can cause ARDS, but you have to be within 7 days of an acute insult. So this is not kind of a chronic progressive disease over weeks or months. This is an acute disease. You have to have bilateral infiltrates on imaging, right? This can be a chest x-ray. This can be a CT chest. These are probably the two most common, chest x-ray being the most common, but you have to have infiltrates in both lungs bilaterally. And then you have to have significant hypoxemia. You have to have a P to F ratio less than 300 millimeters of mercury. Again, definitely check out our basics of ARDS if some of this is confusing. P to F ratios are the amount of dissolved arterial oxygen on an arterial blood gas, the PaO2, divided by the FiO2, or the fraction of inspired oxygen that you have them on. Let's say they're on an FiO2 of 80% on the ventilator, right? And their PaO2 is 100. You would do the 80 divided by, the 100 divided by 80. You make the 80 a decimal, so it'd be 0.8, and then you'd get whatever 100 divided by 0.8 is, 120 or something like that, so less than 300. So these are kind of the three main criteria here. Now, the other caveat to this is it cannot solely be from a cardiogenic origin, right? And the reason this is here is because pulmonary edema can cause bilateral infiltrates, it can cause a low P to F ratio, but pulmonary edema is not ARDS. We went into a deep dive on the pathophysiology of ARDS in one of the previous videos in that playlist, so we won't dive into it here, but it cannot be solely from a cardiac origin, so you have to rule that out before you can diagnose ARDS. But when we're looking at this is really broad, right? These criteria are really broad. 7 days of an acute insult, right? Huge number of possible acute insults. Bilateral infiltrates on chest imaging, and then hypoxemia. Those are the diagnostic criteria. You rule out it's from pulmonary edema, and they kind of fit the Berlin criteria for ARDS, so it's a really broad category. And this is important because it's important to identify ARDS, cast a broad net so that you're thinking about it in a large number of patients. But this really broad net also leads to kind of these large trials, many of which have been negative for showing improvement, other than a few specific things, which again, not to beat a dead horse, but check out that playlist. We go into all those trials. When they do autopsy data, though, on all these patients that met criteria for ARDS, what they find is only about 45% of patients meet the histopathologic diagnosis of ARDS, kind of that diffuse alveolar injury, right, that ARDS should have. So what we know from this is we cast a broad net, and we do it successfully. We diagnose it probably more often than it's actually there, and then we try to study it, but we are having trouble finding interventions that fix it. Paths to phenotyping, right? So what does that mean? It means that we probably need to better understand the nuances of this disease to then better understand ways we can treat it. Q, phenotyping. So people saw this clinically, and researchers took this on, and they said, okay, well, let's try to better understand it. Let's try to phenotype it. Let's try to break it down into smaller digestible bits. The challenge is there's a lot of different ways to do this, and ARDS has been phenotyped in a lot of different ways. Kind of the three broad buckets people look at are severity, so phenotyping it based on severity, phenotyping it based on clinical findings, and then phenotyping it based on biological markers. So if we look at these three different things, we do probably recognize some phenotyping. Most specifically severity, the P to F ratios. This is something we do on ARDS patients. We calculate a PaO2 to FiO2 ratio, a P to F ratio. Okay, and this helps us understand the severity, as we see here. 200 to 300, mild. We actually can just write that in. 100 to 200, moderate severity. Less than 100 is severe. And some of the studies done on ARDS utilize severity to then either enroll or not enroll them in the study. And what they found was for different severities, different interventions seem to work better. Most obvious one is proning, right? Proning, the big trial, the Perceiver trial that looked at proning had a P to F of less than 150. So kind of in this moderate to severe group that it was effective for. So that's an obvious example of phenotyping ARDS because proning may not have worked in mild. And if you just said, hey, everyone with ARDS, let's prone them, the effectiveness of the intervention may not have been as robust as it was when they only did it for kind of this almost severe, moderate to severe P to F ratios. There's some other examples of phenotyping ARDS by severity. Some people have looked at dead space fractions, driving pressure, right? Driving pressure is the plateau pressure minus the PEEP. And there's been some evidence to suggest that a driving pressure less than 15 is correlated with better outcomes, and more things. But as you might notice, at least I think in most clinical arenas, the severity phenotype, the one that at least is more clinically relevant, is utilizing these P to F ratios to break it down to mild, moderate, or severe. All right, clinical phenotyping of ARDS. This is something, again, that doesn't have a center stage in kind of clinical interventions, but there has been efforts to try to phenotype ARDS based on radiographic findings. Different scores, something called the Rail score and the Murray lung score, which kind of looks at involvement of lung parenchyma and tries to say, you know, well, if there's a lot more of the lung involved, maybe that correlates with a different phenotype that might respond differently to interventions. Time to onset, right? Early versus late. We said for the Berlin criteria, you had to be within 7 days of acute onset, but what if it was within 48 hours? Right, versus more than 48 hours, early versus late, and try to see if possibly interventions will work differently for if it was early onset or late onset. And then etiologies. In our basics video, we talked about all the different etiologies, and there's a whole breadth of etiologies. Some are native to the lung, like we said, pneumonia, pneumonitis. Some are native to the body, pancreatitis, trauma, burns. So maybe, depending on what caused the ARDS, it might respond differently to interventions. Now, this again, there has not been, as far as we're aware, any kind of real prime time use to this, these different clinical phenotypes, but something that is actively being looked at and actively being studied. Biological phenotyping. This is where we look at different biomarkers, and there's been tons of attempts to phenotype ARDS based on different biomarkers. People looked at the epithelial biomarkers because, as we talked about in the pathophysiology ARDS lecture, there's damage to the epithelial endothelial barrier. So people have looked at endothelial biomarkers. This is usually from kind of systemic inflammation. People have looked at cytokines. There's been some microthrombosis in the capillaries that contribute to ARDS. So people have looked at kind of coagulation factors. All these biomarker phenotypes, no one has identified kind of a singular phenotype that seems to have a high degree of clinical utility, but there's still lots of attempts going on out there to try to phenotype based on biomarkers. Interestingly enough, there has been a combination of things that has led to two separate phenotypes, and these are the two phenotypes that get the most press and seem to possibly have some degree of kind of clinical utility, and that is the hyperinflammatory phenotype versus the hypoinflammatory phenotype. And the identification and difference between these two is a combination of both clinical factors and biological factors. And what we coin it, and not everyone does, but we think it's kind of physiologic phenotyping. You're looking at both the clinical picture and the biological picture to come up with two different phenotypes. And that's going to be what the rest of this discussion is on, because these are the two phenotypes that are discussed most and the ones that seem to possibly respond differently to different interventions, at least that we have evidence for. So going into hyperinflammatory and hypoinflammatory ARDS. All right, so we kind of wrote them out here just to make it an easier discussion. And this here is our little kind of alveolus lung model. So this here is the alveolus. This here is a capillary. You can see kind of the endothelial epithelial barrier with a thin basement membrane in here. This looks like it's filled with water, but it's not, it's air. And we're going to use this just to mark it up as we go through hyperinflammatory and hypoinflammatory. So to start the difference between these two, obviously one is hyperinflammatory and one is hypoinflammatory. Well named because the hyperinflammatory phenotype has increased inflammation. The hypoinflammatory, decreased inflammation. And this is a relative term. There's still inflammation here, it's just less inflammation than the hyperinflammatory type. And what that really means is when they look at these biomarkers, there's higher interleukins, these are cytokines, inflammatory markers, higher IL-6, IL-8, tumor necrosis factor. There's upregulation of neutrophil activation genes. Neutrophils are an innate immune cell that responds to sites of possible infection and causes inflammation. Whereas in the hypoinflammatory type, obviously, lower levels of interleukin-6, IL-8, tumor necrosis factor. So the thought was, okay, well, we have a definitive difference, right? This phenotype has a lot more inflammation, a lot more inflammatory biomarkers, a lot more kind of immune system activation as compared to this phenotype. What does that mean? Do we see any clinical differences, right? Biomarkers are all great. We could test the blood and we can say this patient has more of this patient has less of this. Well, what they started to see was actually the hyperinflammatory phenotype had increased mortality, fewer ventilator-free days, and higher rates of organ dysfunction compared to the hypoinflammatory phenotype, decreased mortality, more ventilator-free days, and lower rates of organ dysfunction. So if you just pause to translate this out loud, these patients often were sicker, were on the vent longer, and had more multi-organ failure and injury. So these were sicker patients in general who did worse, right? They died more frequently, they had longer stays on mechanical ventilation, they had higher rates of organ dysfunction as compared to the hypoinflammatory phenotype. So now we say, okay, well, we tested blood. This patient has more inflammatory markers, this patient has less. Oh, and we also now see that these patients with more of these inflammatory markers actually do a lot worse. They die more frequently, they're on the vent longer, they have more organ injury, so kind of more systemic effects as compared to those in the hypoinflammatory phenotype. Is there any marker that we can look at that may help us understand if someone's hyperinflammatory and hypoinflammatory? Because that's an important thing, right? At the hospital, we don't really, you can, but it takes a while to get it back, and it's usually not that clinically useful. But said IL-6 levels and IL-8 levels and tumor necrosis levels and neutrophil activation genes, these aren't things that are easily sent just at the bedside in the hospital. But hyperinflammatory often has a lower bicarbonate. They often have more of a metabolic acidosis. They also are more likely to be on vasopressors and be hypotensive. So these are some kind of clinical hints that they might be the hyperinflammatory type. So more likely to have metabolic acidosis. This says high bicarb. It should say higher bicarb because all this is relative, which makes it challenging. But more likely to have metabolic acidosis, more likely to be on vasopressors, more likely to have organ injury like acute kidney injury or transaminitis, so elevated liver function tests, as compared to the hypoinflammatory. So now we saw, okay, if we send it to the lab, hyperinflammatory often has these increased inflammatory markers. All right, bedside, they probably have a lower bicarbonate. They're more likely to be on vasopressors. They're more likely to have organ injury. And now we know that they also have a higher mortality. They're on the vent longer, and they have more organ dysfunction. Is there anything that we can do to help? Oh, wait, there's one more bedside thing. Sorry, we missed it. These patients often have a higher minute ventilation as compared to hypoinflammatory. Right? Minute ventilation is going to be tidal volume times respiratory rate. And on times you set this on the ventilator, but patients can breathe over the vent. So these patients are more likely to be tachypnic with higher respiratory rates and more likely to be breathing higher tidal volumes. Right? They're more likely to be acidotic and sick. So this kind of adds up, right? They're breathing much more kind of robustly and harder to try to blow off this metabolic acidosis and to try to compensate for all this organ injury. Okay, sorry, going back. So is there anything we can do clinically to treat the hyperinflammatory phenotype as compared to the hypoinflammatory phenotype? Because now we see they act different, right? They're all under the umbrella term of, ARDS, but even though they're under this umbrella term, they act different as compared to each other. I just couldn't look at that terrible writing of ARDS because our drawing pad lagged, but okay. But they act different. Well, people went back and studied these two different phenotypes to see if they did have different responses to different interventions. And what they found was kind of interesting. So they found that one of the big interventions that we do, and check out our management of ARDS lecture, but one of the big interventions we talk about with ARDS is we talk about conservative fluids. There was a big trial that looked at this, which means, don't just willy-nilly give these patients fluid. Conservative fluid strategies to limit the amount of intravenous fluids they're getting. And what they found when they looked at these different phenotypes is that if you did conservative fluids in the hyperinflammatory type, you did lower mortality. But if you did conservative fluids in the hypoinflammatory phenotype, there's a little bit of a higher mortality. This is not to say to give these patients a bunch of fluids. It is just to say that these patients are more tolerant of fluids, and you shouldn't deliberately withhold a ton of fluid, make them volume down, whereas these patients are not tolerant of fluids. These patients really, really, really like their lungs to be dry. Okay. They also found that, so PEEP strategies, there in ARDS, there's low PEEP tables and there's high PEEP tables. And what they found in a big trial was there didn't seem to be a difference in outcomes whether you used the low PEEP or the high PEEP table. But when they broke it down by phenotype, they found that the high PEEP strategy improved mortality for the hyperinflammatory phenotype, whereas the low PEEP strategy improved mortality for the hypoinflammatory phenotype. So we found that hyperinflammatory seems to like to be dry, right? Conservative fluids, and they seem to like to be on the high PEEP table. And these are ARDS tables. Again, check out our other videos in the playlist. Whereas the hypoinflammatory phenotype seems to be more tolerant of fluids, IV fluids, IVF, and they seem to like the low PEEP ARDS table. And this is a demonstration of why these phenotypes are really important. And we're going to start to understand these more and more. And I think there's probably going to be more trials looking at how different phenotypes respond to different interventions. Because even these two phenotypes alone seem dramatically different, right? They respond differently to interventions. They have different kind of biologic biomarkers. They have different clinical findings. They have different outcomes. And they respond differently to interventions. So hopefully this was helpful. These are the two kind of main phenotypes that we discussed in the clinical arena, phenotypes that are important to keep in mind when we're thinking about interventions for these patients. Let us know what thoughts, comments, questions you have down below. Definitely check out the playlist in this video's description. We'd love for you to join our Patreon page as well. You can access these notes, ad-free videos, weekly practice questions, and a lot more. So definitely check that out too. We appreciate y'all. Stay well, keep learning. We'll see you next time.